Good morning, everyone, and I thank Dr. Vijay Kumar Bada and his team for giving this opportunity to talk on this most important and first essential step in the management of esophageal carcinoma. So, I'm here to talk on the endoscopy and advances in diagnosis and staging of carcinoma esophagus. As we know, most commonly squamous cell carcinoma and adenocarcinoma are commonly seen. Early cancers are asymptomatic. Patients come to us with symptoms of dysphagia and weight loss. When we do this upper GI endoscopy for their symptoms, we find a nodular lesions or ulcerative lesions which can suggest, and a mucosal, such a mucosal lesion is pathognomonic of esophageal carcinoma. Sometimes during this we take a biopsies for diagnosis, and at the same time we assess the patient with endoscopy for other complications of esophageal malignancy like stricture, tight stricture, impairing his nutrition status, or tracheoesophageal fistula, which can cause recurrent aspirations. So also we assess the anatomical site and other informations. Preferably 7 biopsies have to be taken, although a good biopsy taken, the first biopsy itself gives more than 90% specificity and sensitivity. If the lesion during routine endoscopies, upper GI endoscopies for other indications for like dyspepsia, if we find any small lesions which appears to be superficial, then rather than biopsy, if the endoscopist is confident, they can go for a resection, endoscopic resection, because it gives better diagnosis, and biopsying such a lesion may make it endoscopic resection difficult later. So apart from malignancy, we need to have other differential diagnosis in mind while doing an endoscopy. Like non-neoplastic, you can have esophagitis like drug-induced or eosinophilic esophagitis, esophageal rings or webs, or achalasia cardia. If there is the mucosa is normal, but there is a bulge in the esophagus causing dysphagia, we need to think of other differential diagnoses like leiomyoma, GIST, and leiomyosarcomas. So these lesions which we have shown, the diagnosis is easy. So for early lesions where you have suspicion, we have chromoendoscopy, where we use a chemical to stain the mucosa of the esophagus like acetic acid or Lugol iodine, and we can help in the identifying the abnormal mucosa where and find the specific area where to biopsy. And now with evolving technology, we have virtual chromoendoscopy, which is image enhanced endoscopy. This is an example of Lugol's iodine application. Lugol's iodine stains the glycogen in the normal esophageal mucosa, and the esophageal mucosa appears brown. Wherever there is dysplastic or malignant changes, the esophageal mucosal cells lose the glycogen and they appear white. And the issue with this is not practically possible staining during endoscopy, so this is seldom practiced. And in also taking biopsies, multiple biopsies is a cumbersome process. For example, the guidelines recommend in Barrett's esophagus 4 random biopsies for every 1 to 2 centimeters, which if you see adherence to these practical guidelines, it is very low even among the gastroenterologists. So here comes the role of image enhanced endoscopy. What is image enhanced endoscopy? The endoscopy which we do use white light endoscopy and high definition. So for example, the RBCs take up predominantly the green and blue spectra of the light. So they reflect red, and hence RBCs appear red. Here in image enhanced endoscopy, we especially pass only the blue and green light, not the white light. And when the RBCs absorb this blue and green light, they don't reflect anything and appears dark like brown. So hence we will be able to see the vasculature clearly, and because these are shorter wavelengths, they don't penetrate deeper into the esophageal wall, hence only the mucosa and submucosa is seen. So this helps us to assess the vascular pattern and also the mucosal surface pattern in detail like in a microscope. For Olympus systems, they use the technology called narrowband imaging. For Fujifilm, they use a technology called blue light imaging, and Pentax use eye scan. These helps us to detect early lesions. Apart from this blue light imaging, we have another technology of zooming in. Earlier this was not there. For last 1 to 2 decades, we have zooming of the mucosa, where it will be a real in vivo visualization of the mucosa.